Hello, everyone. Gene Santucci here, and I want to thank you for joining us. I know our lives are so busy with work and kids and all the things and practices what we have to do, and I really appreciate you being with us tonight. And hopefully, as a general dentist and a hygienist, you can pick up one or two little things that you can bring back to your practice on the next time you arrive on Monday morning. So, again, thank you for being here. Thank you, Henry Schein family and the Catapult Education family, for helping to promote this program also. So, when you're looking at the first slide, it may be a little bit weird where you see such a strong title, the Gnathostomatic System Under Attack, and evaluating the destructive effects of acid, xerostomia, TMD, bruxism, and then disturbed sleep. The reason I put this little sleeping child there is that we all wish we could sleep that way every night. And this disturbed sleep will go through each one of these little topics that we talk about, either directly or indirectly affecting them. And hopefully, we can kind of connect these links within GERDs and TMD, erosion, bruxing, and sleep. A lot of these will overlap with one another, but it's the overall concept and how sleep goes in and out of these particular items and how it affects your patients on your daily lives. I guess the most important thing is what is the connection of this to your the practice of general dentistry? I'm a general dentist, been so for over 35 years. The last 15 years or so, a lot of my focus has been on disturbed sleep and talking about that throughout the country, nationally and internationally. So I think the important part is there a place here that fits your private practice? And so we're gonna keep thinking about that as we go through this. Uh, I don't think we can argue with this, that breathing is not optional. And because of that, I like to bring up what we call the survival rule of three. That is that we can survive about 3 weeks without food, and we can survive about 3 days without drinkable water, survive about 3 hours in extreme environments or heat or cold, but we can only survive about 3 minutes without oxygen. And a lot of what we do is what happens when we're not getting those oxygen within that 3 minute period of time? How does it affect all these items that we're talking about? Question: how many breaths does an average human take a day? I had no idea until I saw this in an article and looked it up. It's about 22 or 23,000 breaths per day. And so that system better be working well because that energizes our entire body. We have done miraculous things over the last, I would say, 10 years. There have been more innovations in products and concepts and research. Trying to keep up with this as a general dentist and a hygienist gets to be even more and more difficult as time goes on. And so, we're going to keep up with it all, and we're going to see how these new things, these new items, and perhaps some of these products can fit into our practice today. Along with the oral condition, these are just some of the things that the oral condition then affects all our systemic health. And then directly and indirectly, many of these things are also can be affected by our sleep. This is a chart on the upper right side, and it's by C2C Sleep Solutions. I think either download it or purchase it, but I like having this in the hygiene room because it has all the things that disturbed sleep does. And our patients, when they're talking about their oral care and stuff, our hygienists can bring up some of these items that kind of fits and saying, hey, we're talking about diabetes, how diabetes affect your oral condition and the oral condition affect your diabetes and back and forth. And over on the left side, you can see a lot of the diseases that are associated with obstructive sleep apnea, from hypertension in 35% of the patients to 72% diabetics, and way down 91% nighttime heart attacks. And the problem with that is in young men with undiagnosed or untreated obstructive sleep apnea. So this is some of the overall importance of our sleep, and then we'll get into each of these other items with this thing kind of hanging over us, so that directly and indirectly we can get some idea. So let's start off with something what we think is very benign, and it's saliva. How critical is that? Well, that's very critical. Saliva is part of the erosive process. The saliva covers and performs and forms the acquired pellicle, which covers the tooth surface. This is then affected by lowering pH. What happens when the pH lowers? Well, enamel will start becoming erosive at 5.5 in pH. And then once that opens up, there's dentin at 6.2. So if saliva is not being buffered, if saliva isn't having a very strong acquired pellicle, a lot of breakdown happens with acid attack. If you're looking at some facts, we stimulate about, 1 millimeter a minute or about 1 liter a day of saliva. But the sad part is that at night, we only stimulate about 10% of the daytime flow. Now, why is that important? Well, if at night we get 10% of the flow, if we have acid due to GERDs, we now get an acid influx into the mouth. We have less saliva to neutralize it and buffer it, and that becomes a real concern. What's saliva composed of? Well, most of it is water. 99.5% is water, but it's that 0.5% that has all the good stuff, all the electrolytes and the enzymes and the antibacterials, antifungal components. What can increase saliva? You can chew gum, that will do it. Masseter muscle activity, or bruxism, as we clench and grind our teeth, many times that stimulates saliva flow. And when acid comes into the mouth, hopefully from GERDs, we have the salivary reflex where more saliva is produced to compensate for the additional acid in our mouth. So what causes a decrease in the volume of saliva? The biggest is medications. Medicated people coming into our office, unbelievable. Those of you who have practiced, if I've had for years, people would come in and you're doing their medical history and you'll say, oh my God, okay, you're on blood pressure medication and diabetes and, maybe cholesterol. And that's it. Now they come in with this printed out menu that there's so many medications, you're almost afraid to touch these patients because of the effect of all this on their saliva and the quality and the quantity of saliva. The other thing to think about is that, don't drink just when you're thirsty. Most of the time, like if you're at the gym working out, you worked out for an hour, then you sit down and you have, some water. If you sip along the way, it's much better because you may not feel thirsty for a long period of time, way beyond the time that you should have had some water in your system. So let's look at xerostomia a little bit. Again, polypharmacy is huge. Head and neck radiation is another component, Sjogren's syndrome, and then mouth breathers. Let's look at these individually. Xerostomia, a lot of the studies, show that we're getting decreased salivary flow with age. As we get older, we seem to get less and less salivary flow. We're not 100% sure why, but medications, side effect are still one of the main reasons for it. Personal report, about 2 years ago, I had to go on some blood pressure meds and got after about 2 weeks, my mouth felt like this photograph up here of the Sahara Desert. So I went back and told my MD, I said, look, you got to change. This is unreal. Did change medications, lowered the dose, cut the dose in half, maintaining my blood pressure fine, but I don't have the dry mouth. So sometimes chatting with your patients if they've asked for a change in the dose or a change in what medication they're on may help. Radiation itself is something else. Radiation for squamous cell carcinomas, they need about 50 to 70 grays, but the parotid is affected by only 20 grays or lower. So in trying to take care of the cancer, which is very critical, many times we're knocking out the ability of that gland to do what it did before. And so it's a balance there between, of course, getting rid of the cancer is very critical. People suffer dramatically with dry mouth. One product I saw, and I haven't seen anybody use it. It's this Voyuta, I think Voutia, and it's like a little portable water pump, and it's a container of water, and it's like in a little pack. And then there's a plastic little tube that comes out to the corner of your mouth, and there's a constant flow of saliva. Whenever I saw that, it reminded me of the crazy guys at the football game all painted up and they've got the hat with two cans of beer and the tube coming down. But people who are in such severe xerostomia state, something like this can help dramatically. Again, multifactorial for medications, and the little the little diagram there says, "I'm a walking drugstore. I feel a lot better now that I've stopped taking all the pills you gave me." And sometimes that's true. And as they see more and more physicians, they just don't take away medications. There seem to be this always adding more medications to the list that they're on. So these are some of the things that happen to treat it. This whole list of things you can. Some people work real well, and others. At the bottom, you see glycerin. And a patient of mine about 3 or 4 years ago, for some reason, said she went to her pharmacist, talking to her pharmacist about dry mouth, and he suggested some glycerin, very inexpensive, and she dips it in with a Q-tip and then rubs it around the inside of her mouth several times a day. And she said this works better than these products, these melts or xylitol products, and not having to sip water all day long. So sometimes the easiest, the cheapest type of situation works well in some people. So what's the big deal about nose versus mouth breathing? Now, babies, as you know, are born obligate nose breathers. They can breathe through their nose while they're suckling on the breast. Over a period of time, if we start getting nasal congestion, allergies, whatever, we don't get the effect of the paranasal sinuses kicking that nitric oxide into the bloodstream, which helps the absorption of oxygen a lot faster. And so with we then turn to mouth breathers, and here we get a dryness of the oral cavity, the oral pharyngeal tissues. We get a lot of inflamed tonsils, a lot of recurrent sore throats, other types of disease states because the air is not being warmed, it's not being humidified, and it's not being processed, and it doesn't have the nitric oxide component to it. So mouth breathing sets up a lot of these other issues that we don't get by breathing through the nose. And these are some of the problems that bring up night breathing and some of the contributing factors, um, especially in children. You have to be really careful in children. And in this hour program, I don't have the time. Normally, my all-day program, I spend an hour on children, children not sleeping and children with ADHD. And sometimes perhaps we can come back and address that if you're interested. But all of these things will promote mouth breathing, which has a lot to do even with the development of the young child's maxillary mandibular relationship. What can we do? Well, here's some products. The saliva check buffer, which is the GCA product, and what it is right in the chair, the hygienist can, if she notices a lot of xerostomia, can check to see, how great is the saliva, what is the volume, and what's the buffering capacity of that. Well, as you look at it, there's a little cup, and you just expectorate into the cup, and then you chew for, I think, 5 minutes and expectorate again, and you measure how much saliva you have. You then get it into the little dropper, and then you put it onto this little COVID-like gauge, and then it comes up with the buffering ability of the saliva that your patient has. So it gives them, you can show them a bunch of charts and stuff, but when you show them their own saliva and you show them that this is why acid is taking care of a lot of, or wearing down a lot of the teeth, as you'll see later, it's theirs and they can understand it, and perhaps they'll take on some new concepts that you may want to give them. I put MI paste in there. I like to use that on a lot of the patients after they brushed and flossed, and just rub it on there, spit out, but don't rinse, and leave it on all night. You may have some favorite things that you may use. There's so many products out there. Choose the ones that seem to work for you. Okay, let's move on with bruxism, myths and misconceptions. So several years ago, Jeff Rouse came up with this triangle, and he is a prosthodontist at that time, was in Houston, and he noticed that a lot of his patients had this triad of GERDs, sleep apnea, and sleep bruxism, and how they interacted, the GERDs and the bruxism and the sleep apnea right around. And a couple of years ago, my friend and I added several more items to this triangle that we see also many, many times. And that's adding TMD, periodontal disease, saliva, decreasing saliva pH, and erosive tooth wear. So all of this is combined in one, and it may not be in every patient, but in many patients, there is this total combination. So, what do we think about bruxism? Do teeth wear down solely by bruxing? What is the cause of bruxism? Are all bruxism alike when you brux at night while asleep? Is that the same as bruxing during the day? And does splint therapy really stop us from bruxing our teeth? The other thing I can mention is if you're looking at this, this is being worn down, but you don't brux down here. There has to be other rationale behind this, and we'll get into some of those concepts. So, expanding your view of bruxism, think of bruxism as a wear problem, not just grinding. And if you're looking at it, you're saying, okay, it's a wear problem, but what else comes into play here? Well, a lot of it is acid. And when the acid hits, you can get into attrition, abrasion, abfractions. That is magnified by having the acid in the mouth with the parafunctional activity. Now, there's a difference between sleep bruxism and awake. Sleep bruxism is a sleep disorder. In essence, it is centrally mediated by the brain. You start grinding your teeth at night because of the message from the brain, and we'll get into that. Daytime bruxism is an environmental problem. It could be a habit, biting your lip, biting a pencil, grinding your teeth forward while you're at the computer, something that is within your ability to change. So there is a difference. And in making a night guard, are we taking care of the problem? Patients will say, okay, Dr. Santucci, you may be a night guard, so I'll stop grinding my teeth, right? And the answer is no. And we'll get a little bit deeper into this. Now, this is an important concept when we're looking at what does snoring and breathing have to do with parafunctional activity. If you look at the blue on the bottom, you'll see OSA, obstructive sleep apnea. That means that there is no oxygen or very little oxygen going to the brain. The brain says, now, hey, I don't want to die, sends a message to the heart. We get into tachycardia to get the more oxygen going to the brain. Then also there's a message that goes down via the trigeminal nerve to the masseter muscle, and you start grinding your teeth. This is called rhythmic masticatory muscle activity. At the same time, this lack of oxygen builds a negative thoracic pressure where the diaphragm comes up, pushes on the base of the stomach, and up comes the acid and into the mouth. And you have now this scenario of sleep bruxism. This is a critical understanding of most of what I'm going to talk about today is the effect of oxygen on the brain and then what it does to the body to help us survive. And what we don't know is, and this may happen, this heart rate going up, people will go into this obstructive issue 10, 15, 20, 30 times per hour. So the heart, you're going tachycardia, 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 then it's got to stop. You go bradycardia, 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 and you're going up and down, stop, start, stop, stop. And then we wonder why so many of these people have cardiac problems. Diagnosis of bruxism, wear in itself is not a good indicator. As I said, there are parts of the teeth that wear down that don't even touch. Self-reports are not reliable. There are studies, I don't have time to bring it up, but people who say, I do grind my teeth I grind, and they actually don't when you do EMG studies, and those that said they don't actually do. But we're not going to do, EMG studies on everyone, that's for sure. So sleep bruxism, let's look at that. So it's repetitive jaw muscle characterized by clenching or tooth grinding. It is brain controlled. Again, the brain is in charge of this. Awake bruxism, this is something you don't have to do. It's non-functional. And these are habits that you have picked up. This is something you have control over if it's something that you find yourself doing. So a distinct difference between sleep bruxism and awake bruxism. And the effects of occlusal splints for sleep bruxism, you have to be very, very careful. Some studies are being done where if you make a traditional occlusal night guard for a patient because of their wear or your veneers that you've just placed or whatever, and you have no idea if there's a hidden sleep problem, the traditional occlusal splint or night guard may make that problem worse. And so you have to be a little bit careful. There's a difference between making an occlusal splint or making a mandibular advancement appliance that we use for sleep patients. So I'll show you how to maybe have a little bit of an idea of how to take care of this. So you can see here that maxillary occlusal devices in patients with a diagnosis of sleep apnea were associated, if you make just a maxillary regular occlusal device, that 40% of the patients, it was a small study, actually their sleep diagnosis became worse. So the cause of sleep bruxism is usually not occlusion. It's not occlusion. And this hurts me because years ago, I was so heavy into occlusion. Years and years ago, we'd use articulators, all types of fancy devices, taking impressions, uh, over putting the restorations back onto the models, adjusting them, then going back into the mouth. And then at the very end, with this beautiful occlusion with posterior maxillary intercuspation, fantastic protrusive and lateral obtrusive guidance. And at the end, what do? We make a night guard. Well, if occlusion or lack of occlusion or destructive occlusion was the responsible entity for sleep bruxism, after we did all this, there's no reason why we would need a night guard, right? So again, a lot of this is not related to occlusion. It is oxygenation, lack of oxygen, and the brain saying you better start clenching and grinding your teeth, taking a big deep breath, and saving your life. Now, here's a diagram showing this, or one of the sleep studies. And on the top line, this is the EMG of the masseter. And then down here, you see the sleep, the airflow from the patient. And then everything is cool. Right about here, the patient stops breathing. And during that 22 seconds, they stop breathing. Immediately, what happens is that the masseter goes crazy and it starts clenching and grinding, wakes up the patient, and now we're back to a normal airflow. Where here the airflow had stopped, we had clenching and grinding from the brain, and now we get normal airflow again. So that's very, very critical. And the only times you will see this is actually with sleep studies. So effects of bruxism. So bruxism, I'm not knocking the effects of bruxism. Improvements of occlusion may help control the impact. So if you have teeth that for some reason are hypersensitive, or in lateral excursions, you have picking up of the triangular ridges, something that is making these teeth sensitive, even mobility. Yes, localized occlusal adjustment is fantastic, but it is not the occlusion that is causing the bruxism. And I think for me, that was a huge, huge difference in my thought process. This is another study that shows that if you don't know what's happening with your patient prior to making an occlusal splint, you should at least do something to get questions or answers to say, is there a sleep problem going on? What if there's TMD and there's a TMD problem with your patient? Do you not suggest your patient go and have a sleep study done or having sleep therapy done? And a bunch of records and a bunch of articles say that having a TMD problem is not a contraindication, that in most cases it kind of calms down some of the problems because of the stability of the appliances. Again, it is patient by patient, but in general, there should not be a lack of treatment for patients, sleep treatment with TMD appliances. This also surprised me. Who clenches and bruxes their teeth? Highest are children, 14 to 18% of children and adolescents. And as you get older, it just seems to get less and less and less. I thought it was kind of the other way around originally. And this is a very strong presentation out of Journal of Pediatrics, and another one out of Chest. So yeah, children, and we have to watch these little ones, little kids who clench and grind their teeth while they're sleeping or make snoring sounds. It's not cute. It has a huge, huge effect on them, and it's affecting the prefrontal cortex of these young kids who are not getting enough oxygenation. So as I said, sometimes it would be good to come back and just do an hour just on children. Again, occlusal appliances. This is the traditional Michigan night guard, which we've always made for years and years and years. And this is the one that, if you don't know what's going on, be careful. And, looking back over the years, why do we make occlusal appliances? Well, for wear, sure. Um, some people use them for active bruxism, verified or not. I'd be very, very careful with that. And temporomandibular disorders, you have to be careful on how you use the night guard. So I guess my point here is that it seems to be a very innocuous little piece of plastic. So instead of you trying to really improve a situation, if not properly made or knowing the etiology of what you're trying to improve, this may actually cause more of a problem. I like this product. It's called a Quick Splint. It's by Kettenbach, and what it is just this shell, shell, and then you fill it with either bite registration material or putty, and you can do it maxillary or mandibular. And I like this for two reasons. Number one, Friday afternoon, 3:30, 4 o'clock, you get a call. Mrs. Jones, one of our longtime patients, called. She's in a lot of facial pain. She's nervous. She's apprehensive. She's been clenching. Her daughter's getting married tomorrow and she's in a lot of pain. What are we going to do? Well, have her come in. I have no models. It's 4:30 in the afternoon. I don't have time to pour models, take models, do some type of a pull down. This is something that I can do in 2 or 3 minutes and see what the relief is, their relief. So it's also a temporary, again, it's a temporary appliance. It's not something you use long term, but also diagnostically, if this appliance decreases the amount of discomfort, we can then feel comfortable that the source of the pain is coming extracapsular. If the patient experiences an increase in problems, then the problem is intracapsular and a much more difficult situation to deal with. So I like it. It has two things. It's diagnostic and either gives me something to immediately put in the patient's mouth to make them more comfortable. So we have a patient we want to make traditional night guard for. Here's something we can do. This is called Stop Bang, and this is just a screening questionnaire. And this is something in your office you should have for every new patient or old patient. And it gives you a little bit of an idea if there is a sleep component to your patient's background. And here, 8 simple questions. Do you snore? Yes or no? Are often tired during the day? Have you been observed to stop breathing while sleeping? And are you being treated for high blood pressure? What is your BMI? And I like this particular chart because it has you don't have to get your abacus out. The BMI chart is right there. And if you're age 50 or older, neck circumference, male and female in gender. And if you answer yes to 2 or more, you are at risk for obstructive sleep apnea. And 3 or more, you have moderate to severe. So this is one little survey. And the other one is called the Epworth Sleepiness Scale. And the questions are, is there a tendency, would you ever fall asleep? Would you never doze, slightly doze, moderate chance of dozing, say watching television, 0 to 3. 3 would be a high chance of dozing. Lying down to rest in the afternoon. My wife, dear heart, the one in the car, bless her heart, we're driving in a 2-hour drive somewhere and, we're not even out of the driveway and she's already asleep. And I joke with her when we're coming back. And after 2 hours of drive, I'm ready to pull in, and she wakes up and says, "Hey, can I help?" I said, "I think I've got the last 10 feet here, right?" So, but some people are just like that. It was a little kid in the car put her to sleep. But anyway, getting back to my point, the first one, the Stop Bang, is objective, and this one is subjective. And you look at the scores, and if they're scoring high, you may want to hold back from going to a traditional night guard. Recommendation is you refer them to their primary care physician for a sleep study, or to any local dentist who is a qualified sleep dentist or diplomat sleep dentist, and can also take care of the patient at that time. But you bring to their attention that there may be a problem with sleep, which is interfering or affecting their entire body. So look at TMD again, and again, this is a traditional view, and patients come in and say, "Oh, Dr. Santucci, do I have TMJ?" And I always say, "Oh, well, I hope you have two." And they look at me not knowing what I'm talking about, and I'll say, "Hey, you've got one on each side." So we know it's temporomandibular disorders, and it's a collective term, and it's all the masticatory tissues, the temporomandibular joint, the associated structures, but it's not a dental diagnosis. It comes under musculoskeletal disorders in the medical field, and it's listed under myasthenia gravis, carpal tunnel syndrome, and all of those. And so patients that go beyond just a night guard treatment really have to be treated with medical CPT codes and not those that we use in dentistry. So a lot of anxiety and disturbed sleep in some of the patients who have a lot of anxiety. If we're looking at signs of TMD as we're evaluating our patients, signs, of course, are something that we can see, measure. And so, for example, TMJ noise or mandibular deviation, facets, etc. And, perhaps, if there are, say, 80 people on the view, 80 or 90 people, about 75% of us should have some sign of TMD. And most of the time they are, yeah, I have these joints are clicking and has there been any trauma? No, it's as long I've had it a long time. It hasn't changed. Then I usually ask them if there's been any locking where they couldn't close and how to get it professionally, and either yes or no. But there's signs. There's something that we can go in there and manage. Symptoms, on the other hand, are subjective. We can't see symptoms. It's pain usually, and there's a trauma either directly or indirectly to a particular spot. We get a constriction in blood supply. We get an inflammatory process that starts. We go into muscle soreness and spasm, and then we get pain. And again, we go into pain. When do you get it? Where is it? If it's severe, some people deal with referred pain, where there are trigger points that are injected. That is way beyond my scope or beyond most GPs, but there are people who do that, a facial pain specialist. So that would be what we would call a symptom. But only about 5 or 6% of people actually seek treatment. Most of the things are within their daily lifestyle. They stay with it, they cope with it. It's not a big deal. And most reports are showing, recent reports, for 4 to 1 that women seek care. Well, that makes sense. I mean, women with the children, taking the children to the physicians very, very quickly. And guys are, we just kind of hold back and it'll go away type of an attitude. So that doesn't surprise me. There was a study done in Australia on orangutans, and they found that in the female orangutan TM joint, there are estrogen receptor sites. So there may be a hormonal component to this also. I notice in my practice, a patient who's been on a night guard, they're doing very well for a year or whatever. They give me a call, hey, something's wrong, it needs to be adjusted. They come in and they say, oh my God, all of a sudden I'm having pain here, here, and here. And I'll look at them and I'll say, if they're of age, of course, you're pregnant. And they'll look at me like, how did you know? I said, well, it was a wild guess, but I've done this before. What happens during pregnancy? All of the ligaments, let go. They start stretching. They become more elastic. Thank God, or else in the hips, we'd never have any births, right? But the ligaments throughout the body undergo that relaxation. So the ligaments in the joint itself are relaxed, and you start getting more mobility. Things may act up, and usually I tell them, hey, after you deliver, 4 or 5 weeks later, you should be back to normal. And just to give them some idea of that, hopefully this will turn around. I throw this up just for a psychological value. This is a young hygienist. I think at this time she was 24 years old, running around the country seeking care for her facial pain. And I don't know why someone would not stop with the endo and the retrofills after several. The young lady knew all the things to say and how to get treatment done. And all I can say is that if you see a radiograph like this and they come to your office, just don't pick up a handpiece. Sometimes we can say, I'm sorry, you're beyond my scope of care, and send them to a facial pain specialist. But many times I think some people like this may need some psychological counseling or care. So again, we just kind of throw that in just to wave a flag. Let's talk a little bit now about acid. So far, our learning objectives, we're looking at, disturbed sleep in general dentistry. What shift in your possible dental practice could you bring into play? And we're going to use a term tribology that you may or may not have heard about before. What brings on excessive dental wear? And this one I put in red, bruxism as a sole source of dental wear. And then acid is intrinsically and extrinsically affect on the dentition. And how does our dental team or your dental team view this now? Is there perhaps a different change in how your concepts go as to how you evaluate and treat your patient? So mechanisms of dental tooth wear. So there's a chemical effect, and that softens the tooth surface, the enamel and the dentin, and they can either come by dietary or intrinsic acids. There's a mechanical component, which is the relationship of the attrition and the bruxing and abfractions. And then there's behavioral, which are people doing certain habits like biting their nails, etc. So this all goes together under what we call related tooth wear. So how do we deal with this? We may look at controlling the acid that comes into the mouth, protecting the teeth from the acid once it's there, and perhaps even minimize some frictional forces. So what's the difference between caries and erosion? Well, caries involves bacteria. Erosion, there's no bacteria. Caries can be reversible by recalcification of E1, E2 lesions. It's irreversible. There are just surface lesions, and it's not a reversible situation. pH in the mouth, 4.5. Why is that critical for caries? Well, stronger than 4.5, bacteria can't survive. And so there's no bacteria. Yet with erosion, it doesn't matter because the erosion will go down to 1.2 whatever, and it doesn't need bacteria, and it slowly eats away first through the enamel and then through the dental itself. So two different methods of involvement with acid. Caries needs a pH above 4.5, and erosion doesn't really care. Again, we get back to saliva making and fabricating the acquired pellicle, which covers the tooth surface and tries to keep erosion occurring by neutralizing the acid, both the amount and the quality of the acid. So a lot of the acid attack depends upon, of course, the pH. How strong is the acid? And then again, your saliva, how can it buffer it? And you saw the little buffering kit to give your patient some idea of buffering and how that works. And then how is your drink? It sounds silly. How do you drink your drink, right? Well, are you just, downing down a can of Coke, or is that sports drink sitting at your desk? You have that gallon of it with the straw and you're sipping on it all day long. So you're constantly bathing the teeth in acid all day long, other than one time where the acid can kind of come in and help. And then how long does it stay on your teeth? Does it stay there? And what's the consistency? Is it something that just goes down when you swallow, or is it kind of sticky and gooey and sticking to the tooth and keeping the acid there also? And again, what is the thickness of the pellicle and how does this resist this acid? So here's the term tribology, and I bring this up. This is from science, and it's the in general saying the interacting surfaces of two surfaces in motion, rubbing against themselves. And they can, depending upon what's between them, it can be attrition, which is maybe just your saliva, or abrasion, where you have something that's a much thicker in consistency and brings about stronger breakdown. So that's the term tribology. When you're looking at this and you're saying, oh my goodness, what's the primary cause here of this tooth breakdown? Is it just bruxism? Well, I don't know. It's hard to see bruxism with this type of scooping out effect here. Here, you don't function out here. So how can you say it's bruxism? I'm not saying bruxism doesn't occur. But when you see a case like this, what does that do? First of all, it's an extremely difficult case to manage, even for a prosthodontist. We have more than likely, there may or may not be a loss of vertical dimension. It depends upon compensatory supereruption. But then let's say you have enough vertical here. How are you going to, what are you going to do to these teeth? You try to go in and prep these teeth here. They're probably shells to begin with. There's not much to prep without everything falling apart. So my point is, can this have been seen or saved years ago if the patient was being seen? If the patient was not seen, then it's not our problem or not our fault. Up here, you can see that there is a lot of breakdown, but we don't have any decay. And that's because with the acid, there are no bacteria. So that's another important point. So let's look at the acid erosion. Where's the acid coming from? It could be extrinsic or intrinsic. Intrinsic can come from the stomach, of course, and that can be GERDs, bulimia, anorexia. Bulimia is if you see a case like this where you have a lot of wear on the lateral aspects of these anterior teeth, that is from the bulimia from the acid coming up as the patient is just voluntarily throwing up, and the acid invades these teeth. So sometimes that's a clue, and with that, sometimes you can help the patient by seeking care and let them know what's going on with their teeth as they keep doing this. So, as I mentioned before, that when you go into a sleep deprivation, there's a negative thoracic pressure that builds up, and the diaphragm pushes up on the base of the stomach, and then that opens up the sphincter, and then the acid comes up the esophagus into the mouth, and maybe even up into the sinuses. A lot of people with GERDs for a long period of time has precancerous lesions. Barrett's esophagus is a precancerous lesion in the esophagus itself. Now, why is this so critical? Because we are inundated with protein pump inhibitors. You ask your patient, Mr. Jones, do you have GERDs? Oh, no, 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 I take Prevacid every day. Oh, I know you take Prevacid, but that means you have GERDs. Oh, no, no, I take Prevacid. I can eat whatever I want. The problem is, do the physicians, bless their heart, have enough time to deeper as to the etiology other than just prescribing something to mull it over? And of course, your manufacturers aren't going to say anything because, hey, 14 billion a year in sales. Let's keep pushing the protein pump inhibitors. How about extrinsic? They're intrinsic, extrinsic. All of these fruits and juices and soft drinks, sports drinks, all the way down even to medications. And the concern is that more and more it's increasing, especially among young kids. They want to be like their sports heroes, and they're drinking all these sports drinks that are highly, highly acidic. And we're seeing a lot more breakdown and fluorosis on some of these teeth in young children that we didn't see before. So again, this was a study done where extracted teeth were placed into these solutions, all of these sports drinks, Red Bull down to Coca-Cola. And Red Bull won as far as the amount of dissolution of the extracted teeth. Now, you would want to think, how about Coca-Cola? That's pretty bad. Well, there's a difference in the acid. The acid in Red Bull, Coca-Cola, I'm sorry, is phosphoric acid. In Red Bull, it's citric and malic acid, which are stronger acids. And so this is where the energy drinks, and especially if you drink them all day long and they just sit on the gingival, on the teeth all day long, there's a lot of dissolution. If you look at this and you say which one is the most damaging, well, surprise, surprise, chocolate milk. There's some acid in there, but the fact that the milk is sticky and gooey and sticks on your teeth for long periods of time gives the acid more time to respond. And which is the least erosive? Surprise, surprise, Coca-Cola here, because of the phosphoric acid, as opposed to the stronger acids in the others. So we're looking at early detection and extensive treatment here. And again, a lot of teachers saying, okay, in the background, though, there's sleep. And, the acid is coming at night from how you're sleeping or not sleeping because of apnea. And during the day, you're consuming all of these drinks with high acid content. And then you're wondering why, with some parafunctional habits, why we're getting a lot of excessive wear. So all I'm suggesting is that we do a fantastic job both as a dentist and hygienist in internal oral exam, external exam, looking for caries, periodontal disease. May I suggest you just look a little bit further back in the throat and evaluate your patient for some possible sleep problems, which may be bringing on acid and other things that we're concerned about. And again, just putting that stop bang and that upward survey into your office, I think will open up your eyes to how many people do have problems. If you're looking at these broad classification of tonsils, tonsils are one of the biggest reasons why people are obstructive. They can't breathe, and then if they have some allergies or nasal problems, they're really under concern because they can't breathe through the back of their throat and the front of the throat, and the nose is also constricted partially. So look at the tonsils, and removal of the tonsils is one of the easiest way of helping people getting back to normal breathing, along with these other items that I can't go through list by list. Scalloped tongue. Why do people have a scalloped tongue? Down syndrome, most Down kids have larger tongues, the same with hypothyroid. Apert syndrome is a developmental difference between the maxilla and the mandibular in the growth, early growth. Amyloidosis is protein deposits in all the tissues in the muscles, and the tongue is a muscle. But the biggest part of the apnea of the scalloped tongue is sleep apnea and parafunctional activity. Remember, when the patient is apneic, a message goes down to the trigeminal nerve, to masseter muscle, clench, 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 and the patient then opens the mouth, takes a breath, and the tongue comes forward. And you can see here scallops even on the anterior portion of the tongue. Malapati index, this is probably something you haven't heard of before, but again, having your patient stick their tongue out, looking at the back of the throat, and looking at the classifications anywhere from 1 to 4. Number 4, you can hardly see anything with the soft palate hanging down. At night, this tongue goes back and even blocks the structure even more so. Short lingual frenum. There's a fight as patients are growing between the buccinator muscle pushing in on the maxilla, and as you swallow, the tongue goes up to the roof of the mouth and neutralizes that. But if it's restricted, the tongue doesn't reach the roof of the mouth, and so the buccinators are winning, and instead of getting a nice dome palate, you get a very vaulted palate, and again, you don't have room for the tongue, and you have obstruction and a sleep problem. So what do we do? How to modify the environment? There's so much out there that we can possibly get into. But again, is there things we can look at and help our patients, not just with the teeth and the periodontal tissue, but looking at them totally for total body health? We looked so far as disturbed sleep, tribology, excessive dental wear, bruxism, the types of bruxism, acid, internal and external acid, and then looking at our team and how do we change, if we're going to change anything or add to our means. This is the perfect dental storm. You have a patient who doesn't sleep well, has bruxing, sleep bruxing, has GERD, poor saliva, and breakdown with erosion. This is what I would call is the perfect storm. And many times, just by taking care of the teeth, it doesn't solve this at all. Staggering fact that in 30 years, studies are showing that without acid in the mouth, the wear on the teeth is about 1 millimeter without acid in the mouth. And so, if we're looking at helping our patients manage, do we just observe and wait? Do we change their behavior? Do we apply fluorides, sealants, restore? And a lot of this is like when you're looking at these class 5 lesions, it goes back to why are they there? And when I went to school, Grippo studies said that because of the trauma on the teeth, especially in the lateral excursions, there's a slight bending at the neck, and these little enamel asperities are kicked out, and over a period of time, this is what we're seeing. Abelson did some studies, and he said, hey, I can duplicate this in the laboratory just by the different types of abrasiveness. So again, it depends on what school you're coming from. I kind of like more of the occlusal theory. Again, that's just my personal belief. He said just by brushing, depending upon the type of dentifrice he uses, he can cause it again in the lab. And whenever you look at a toothpaste, look at the relative dental abrasiveness. You can look at the RDA on each toothpaste. It should be 250 or less. And if they're using something more abrasive, they may be actually causing some of these. But I'm sticking a little bit more with the occlusal consideration. On these class 5s, there's so many great products out there. I use a Beautiful Flow Plus. I like it from the fact that it stays where I put it, and there's fluoride that's emitted around the borders of your restoration, and I just kind of think that helps. But one of the many, many products, this is the one I particularly use. So when you're looking from a dental point of view, when you're talking about wear, you're really looking at a process, a tribology type of process, but then you're also looking at the acid that is setting up the teeth for destruction. And you have to look at both venues to try to figure out which one is the most important. These are some slides showing the red is the baby boomers, and you can see as they're coming up of age, they're getting larger and larger and larger. And here in 2020, you can see that a lot of our patients that are 75, 79 years old, years ago, we would just say, well, just take care of this. We'll just kind of keep the status quo. Today, what do we do? We're doing implants. We're doing everything on these patients. There's a situation where they're essentially outliving their teeth. And so if we don't get in there sooner and don't understand the effect of acid, don't understand the effect of sleep, don't understand how this all comes together, we're winding up with situations like this, which are monstrously difficult to take care of over a period of time. And again, 80-year-old comes in, she wants veneers. Well, if they want a veneer and that's what they want, heck, who are we to say no? The other thing to consider is that when you see the patient for the first time, it is just a flash in time, which means that you're looking and there's wear. And you're saying, Mrs. Jones, I think you do a lot of clenching and grinding your teeth, and there's a lot of wear, there's a lot of acid in your system, perhaps. And they say, no, I don't. And you say, well, I see this. And it's, no, I used to 10 or 15 years ago, but I've changed everything around. What's my point? You're looking at the status quo at this particular time. Some of this destruction may have happened years ago. So be sure that you put the temporal component into it so that you know that it's up to date or something that you're seeing destruction for years and years ago. So teeth that are softened by acid, 27 times more susceptible to abrasion and attrition than normal teeth. Remember, 30 years normal without acid, 1 millimeter of wear. Look at all this with acid, 27 times more susceptible. And again, where can the acid be coming from? We'll talk about sleep with GERDs coming up while you're asleep. We're talking about the drinks that you're drinking with the acid in them, combination of both or one or the other. So some things you can brush before a meal. It closes the orifices of the tubules, not after. If you just had a meal and then you brush, all the acid that's in your mouth, you're now pushing it down into the open orifices of the tubules. So, brush before a meal, which seems weird, but if you think about it, it makes a lot of sense. And cheese. If you're a good parent, of course, you always have cheese. So if your child is having to drink something with acid, then you always give them a couple of cubes of cheese, right? It's always quiz our audience how many women walk around with cheese in their pockets, right? But again, that will neutralize some of the acid. So strategies very quickly. When you see something like this, do you treat it now or don't? I do. I'll go in there and I'll do these as occlusals. I'll just roughen it up, etch and bond, put some flowable in there and call it a day. And I charge the patient for restorations. I like Grandioso by Voco. There's so many of these great ones out there. This is one that's just been comfortable for me. It wears pretty well, so I feel comfortable in using that. Sometimes, we saw this before, that's important to look at tooth wear. And again, we talked about GERDs and bulimia. I don't want to repeat that again. We know what that means. If you're looking at this, it's just strange. What side do you think the patient sleeps on? Of course, left side, right? Look at all the acid just sits here all night long on the left side, where there's hardly anywhere on the other side. So that may be a clue. So the bottom line is, could you have diagnosed these sooner other than waiting over a period of time? Now they're totally destroyed. Now that we know so many new things, could we approve this faster? There's so many new things with minimally invasive care out there that and there's some new dental codes which allows us to use things like silver diamine fluoride, which I don't particularly use all the time, but alternative to sealants for specific site prevention, unspecific preventive procedures, localized delivery of micromicrobial agents. So there's a lot more things out there that some of these minor things can fall over. But those occlusals, I charge them as occlusal restorations. Applying fluoride is great. This one just CA. I like this one. I like Profacil by Kettenbach. The difference is that when you put them on, they don't turn orangey or yellow. They stay very clear and they have a protective layer on the tooth, which is great. Sealants have been around for so long, they're getting better and better and better and better. A lot of these sealants and flowable composites, good studies even after 5 years. And again, you can go in there, block it off, keep the acid away from the dentin underneath, and hopefully keep down the destruction over years. Unfortunately, when you're doing class 2 lesions are the worst to diagnose for me. Studies shown that only about 12 to 50% of cavitated proximal lesions you can actually pick up clinically. Radiographically, you think they're there. Is it an E1, E2? Has it gotten into the dentin? We don't know, and you want to watch and wait. Something on the market that I've seen for a while now is using chemotherapeutics versus microsurgical. So using chemotherapeutics other than picking up a burr or doing supervised neglect may be another way of viewing things. This is using the KVO's infrared transillumination mode. It goes on either side of the tooth, and you get the NRH light that goes through. And what you then get is really, truly interproximal evaluation. And here you can see that you still have some enamel here. Here you don't. So this one I would take care of. This guy I would hit with um, oh, I'm sorry, and you also can hit the different views on that transillumination to see if a lesion you have or a filling that you have is still have active decay around it, which gives you the ability to redo it or not. On those interproximal lesions, Vivardis as a product Alicum Curodont, and over a period of time, it is shown to remineralize those interproximal lesions. So again, these are new concepts, new things that are out there. And I guess it boils down to when I look at the very end, we're running out of time, that, we're no longer just, hold fillers in the mouth. We're physicians of not only the oral cavity, but also in a position to help our patients with total systemic health. If we pick up a patient that has a hidden sleep problem, and they have it treated, not only can we improve their health, we can also possibly save their life. And I'm not saying that as an overstatement. That's very true. So talking to our patients about health, talking about minimally invasive procedures, may shine a total new light on how we see our patients and their oral care. And I want to thank you. I know that's a lot of material we went through tonight, and happy to stick around and answer any questions. And sometimes we may come back and either do an all-day show or even one for children for an hour or so. So whenever you need that, I'm happy to help. And if there are any questions, I'm happy to stick around and answer your questions.
We do have a couple of questions in the chat, so I'd like to start off with the first one. How do you manage to build up the QS to get better anterior stops? Because there are some patients who need to be off of their canines to reduce muscle activity, etc.
Okay, so it depends on your philosophy of occlusion. My philosophy is that the best occlusion is in maximum intercuspation, all the posterior teeth touch, and we have about a millimeter space from cuspid to cuspid. And then as soon as the patient goes into protrusive or lateral intrusive, then you pick up that anterior sextant to free the posterior teeth in all excursions. So in some patients, you may need to use all six, and in some patients, you may need to use the cuspid. But if the cuspids are a problem, you may want to incorporate all of the anterior sextant in the disclusion process. And not seeing the case with the models, that's my best judgment at this time. Thank you.
Early evolutionary evaluation of narrow upper and lower arches. Ortho is there to expand. And will it increase airway and relieve breathing issues?
Yes, and in fact, when you talk about children, one of the first steps in children who are having breathing problems is to expand the arches, of course. The other thing is to relieve the lingual frenum, because the lingual frenum, if it's restricted, is keeping the buccinator muscles if you don't release it, the buccinators take over and you get a very high palate in the child. Once you release it, the pressure goes up and you get neutralization, but you need arch expanders to do that. So stage one ortho is critical in children. And as I said, the children are the low-hanging fruit. If they are having breathing problems at an early age, this brings on problems for the rest of their lives. The children who are not breathing properly are similar to children with ADHD. You put them in a room of 100 of them, 50 and 50, and evaluators cannot tell the difference between which child is not breathing and which child is ADHD. And unfortunately, just about everybody is put on Ritalin by mistake. So it affects the same part of the brain, the anterior prefrontal cortex, and I get really all psyched up about talking about children, how we can help them.
So on that note, how do you address grinding habit in children?
Well, why are they grinding? We always want to come up with putting something in the patient's mouth to stop things. Why are they clenching and grinding? Most of the time, they're clenching and grinding because they're not breathing. And as we said before, if you're not breathing, the brain says, I don't want you to die. And so it sends a message down to the masseter, trigeminal nerve, to have the child clench and grind their teeth to wake themselves up in order to take a breath. So the first thing I do, a child who is doing that is instead of going to an appliance, which is hard because they're still growing, have them check for allergies, have them check for orthodontically. Do they have pneum? Do they need expansion of the arches? And are there allergic problems, which gives them a blocked nasal airway, and then they have to breathe through their mouth, and now they're drying up all the tissues, and they get all the other problems that comes with not having sufficient lubrication and humidity of the air that you're breathing. So for me, I would get an allergy check. I would have an orthodontic check. I would go to someone who knows how to treat sleep in children and stay away from an appliance unless you really know what you're doing. And I don't treat children because it's really delicate to do it. But I get a little bit nervous if you're just trying to make an appliance for them.
What is a code for the saliva test?
So there's a D1999 unspecific prevented procedure. You may want to try that. Okay.
Is snoring always an indication of sleep apnea? Can't it be due to other issues like DNS?
Well, there's two things. You have snoring, which is hypopnea, which means that you're still getting about 30%, or there's a decrease of 30% of the oxygenation. Apnea is that you're down to zero. So you're not getting hardly any oxygen at all. So is the snoring, how many, well, when you have a sleep study done, they measure two things. How many times per hour are you totally apneic, which you stop breathing, and how many times per hour are you hypopneic, which is still snoring? And you add those two together, let's say there's 10 apneas and 10 snorers, that's 20 over 1 hour. So you add those together, your score is 20 divided by 1, which is 20. So on a scale of 1 to 15, it's moderate to low grade sleep apnea. Above 15 and up, you're starting to get into more severe. So without a true sleep study, it's really hard to A, diagnose the etiology, and two, what type of therapy you're going to deliver. You have to start with a diagnosis, and that's made with a sleep study, and the sleep study read by a licensed physician, sleep physician.
How to treat the severe erosion, patients on the buccal surface or on posterior teeth except crowns?
Mhm. Well, again, we have to go back to what's the etiology? Why is it there? If we don't know why it's there, we're just throwing things at the teeth themselves. Is it there because of acid coming from where? Is it coming from GERDs? Is it coming from a sleep problem? There's got to be an etiology somewhere. And then, so along with coating the surfaces, we also have to deal with what is the source of the etiology that's breaking down this structure. If not, we're just chasing our tail around in a circle. And so if we know that the patient does have a sleep problem, we know that they're on one of the protein pump inhibitors, we know there's acid in the system, then it's looking at, is there something that would go with their physician? Is there something in the diet? Is there something that we could decrease that acid? Can we increase the quality of saliva, the buffering effect of the saliva? What's their what are they intaking? Are they taking more acids during the day? And so it's not just a simple solution. You have to try to look at etiology, and sometimes it's multifactorial before you just start treating something or putting flow bowls on class fives or whatever type of restoration you're going to do. Yeah, we seem to stay away from etiology, and that's the most critical part.
Do you suggest healthy start habit appliances for kids with grinding?
No. How do you keep up with the child's growth? And what are you making the appliance for? Why is the child grinding? As I said, I think it was a question before, that if the child is grinding, clenching and grinding their teeth and snoring, there is a problem. And the problem you're not going to cure with a piece of plastic. You have to find out what is the etiology of why the child is doing this. Is there an allergic component? Is there a sleep component? Something that's causing him to do this. Making an appliance is not going to do anything. In fact, it may exacerbate the problem. So I would be very concerned. There was one for people who treat children. There's an appliance, I think, made by Pantera, and they said that they adjusted along with the growth of the child. that's fine. But first, I want a diagnosis as to what they're treating. And if you're treating them for sleep or you're treating them because you think they're ADHD and there's a problem because they're allergic and they can't breathe through their nose and they're causing all other types of problems, or high acid intake with sports drinks, you have to come up with some idea of where is it coming from. Just throwing appliances at it is not going to take care of your problem.
So speaking of appliance, what are your thoughts on mandibular advancement devices for diagnosed obstructive sleep apnea?
I think they're great. Uh, if you go and you have your sleep study done, most of the time, uh, a physician will prescribe a CPAP machine. CPAP is a great machine. The only problem is there's only about 35% compliance. People don't like them. They seem claustrophobic. It's not sexy or whatever. And so they can just sign off and say, I would like to try a dental appliance, a mandibular advancement appliance. There are about 140 different designs. They're all the same. They all do the same thing. They bring the mandible forward, keeps the mandible forward. So as you sleep in all different positions, it doesn't slide back and close up the oral pharyngeal airway spaces. And by tithering it forward and back, you find the spot where the patients no longer snore and that the temporomandibular joint is comfortable. Now, these appliances, now the compliance is about 80%, 85%. So you have an appliance that, especially for low grade and moderate sleep apnea, is great. If it goes up into high numbers, you may need to combine what's called combination therapy, which is a combination of a mandibular advancement appliance and a CPAP to try to control it, because CPAP alone, high, there's so much pressure that it's hard to keep it on the patient's face. So by using both, we can modify the pressure and the patient can also wear a mandibular advancement appliance. These are severe cases. But when you look at it, most patients do tolerate mandibular advancement appliances very nicely. They don't seem to tolerate CPAPs that well.
I've just heard about a product and technique to treat mouth breathing called froggy mouth. I think it comes from France and almost seems too good to be true. Are you familiar with it?
No. How do you spell it? What is it? Foggy mouth?
Froggy, like the way a frog?
Oh, frog.
Froggy. Yep.
Yeah, I don't know what that is. I've not heard of it. I'd have to look it up. Thank you. And does it say anything about it or just itself?
That's all the person has posted.
Froggy mouth. Okay.
Yeah.
Okay. Now you gave me something to do. Oh my goodness.
This
All
is
right.
supposed to be the other way
Supposed
around.
to be the other way around, right? Don't ask me questions I don't know the answer to. So,
Right. Um, Somebody asked, could you please repeat the name of the pediatric appliance you had just mentioned?
Pantera,
Can you probably spell it? I'll put it in the chat.
Panthera, I think.
Okay.
And if you use that, make sure it's used by someone who knows what they're doing with children, which is really critical. And make sure you have a sleep study done so you know exactly the etiology of the problem and the severity of the problem. And it's not just, one appliance fits all. I personally don't treat children, so I don't know all the ups and downs of using these appliances. I guess my concern is just be careful.
Um, someone posted froggy mouth is for pediatric patients. It restrains the muscles and it deals with tongue posture.
Okay. Um, Mm, I'll have to look up myself. There's also things like myofunctional therapy, where the children are taught to swallow differently. Also looking at restricted lingual frenums to release restricted lingual frenums. So I'd have to look it up. Thank you for that. I will look it up. And until I do, I don't know much more to say about it. But thanks for the information.
What are your thoughts on using something like the Seattle Protocol, Dr. Rouse and Spear, to treat patients versus doing HST and applicable orthotics?
Unfortunately, a lot of these treatments is not one for all. By that, I would have to see what are the results of the sleep study, how severe is the sleep study, interview the patient to see what their experience, interview their oral cavity, interview the muscles of mastication. I have to get all that information together to say, does this person fit a particular protocol or not? I don't think I have any two patients that are the same. And so, the Seattle Sleep Group is a fantastic group, and I've not dealt with them directly or indirectly, but I know a lot of their reputation is a very high standard reputation. Again, I would have to know a lot of the other information before I could say yes, no, or indifferent for the way I treat my patients. But I do highly respect that group.
There's a few more questions, Doc, if you're okay with that.
I'm all right.
All right. Will you have another session on pediatric sleep disorder, breathing, or a course on pediatric airway?
Um, I could do about an hour. If people want to hear that, they'd have to go through you to sign it up. Um, it's about 45 to minutes to an hour just on children. And so I'd be happy to do that in the future if there's enough interest in that, surely.
Parents PCP didn't think a child had an airway issue or disease, then what do you do for grinding?
What was the first part?
I think they're trying to ask that if the pediatrician didn't think the child had an airway issue
Yes.
or any disease associated with
Yep.
the airway, then what do you do for grinding?
Find another pediatrician. And I say that jokingly, but with all sincerity. If let me put it this way, if I recommend a child that I don't treat, but I know that there are things going on, to someone who treats, to the pediatrician, I tell the parent that you're going to hear a lot of negativity. You're going to hear that expanding the palate is not a big deal. Number two, extracting teeth, oh, don't worry about it. Number three, kids who grind their teeth, they'll outgrow it. You get all these negativities. I tell them ahead of time, and if they get that, my recommendation is to find another pediatrician. Find someone who understands the airway, who treats the airway and understands it totally. The problem is that as a child is growing, 4 or 5 years of age, the size of the brain is about 85% developed. Then we just add more sympathetic episodes to it over a period of time as the child develops. If during that period of time they're not getting enough oxygen to the brain, and we're getting problems in development of the child, uh, not my child. I'm not going to wait until he's 8 or 9 years old. He'll outgrow it. What happens to the brain during that period of time? So to me, I would just say find someone. You can check with the American Academy of Dental Sleep Medicine. Find out in your area is an orthodontist who treats children, or a pediatrician who treats children. You can look at the American Association of Sleep Medicine, check there also. But I wouldn't mess around with children. They're very delicate. They're at an age when they're developing quickly. And I always think about, if this is my child, what would I do? I would not wait and see. And that's just my personal, I get nervous about kids who aren't treated properly.
How early would you treat crossbites and primary teeth?
How early would I what?
Treat crossbite and primary teeth.
Okay, that's an orthodontic question. And your friendly orthodontist can give you a better answer than I can. If it's a skeletal developmental problem, that's one concern. Is it just a dental problem? That's another concern. If there's a restricted frenum, that's another concern. So there are many multi different things that can go into the diagnosis. And so I would look at for an orthodontist who also understands sleep in children, and that may be part of it, because if it's a restricted frenum, you don't release the frenum, you're going to get a restricted maxillary arch. You have a restricted maxillary arch, there's no room for the tongue. And this just goes on and on and on. So again, find someone that understands airway in children, an orthodontist who understands airway in children, and not just making the front six teeth look good.
All right, I think that's it for all the questions.